Good afternoon. My name is Jennifer Peterson. I am one of the clinical practice education specialists here at City of Hope in the division of hematology, stem cell transplant, and IEC. So I'm really happy to be back from 2018 to today. There's been so much progress in this area, and it's really exciting to see new products that have come to market, as well as more that are in research and hopefully coming soon to treat patients and have better outcomes. So thank you, Chelsea, for your presentation on CRS. We will go to the next most common side effect of cellular therapy, particularly in IECs, which is immune effector cell-associated neurotoxicity syndrome, or ICANS. And my slides have this really interesting font, but that's okay. Hopefully it's not too hard on your eyes. It's always a surprise when you present. So we're going to talk about the etiology and onset of ICANS, some of the risk factors that put patients at higher risk of developing ICANS, some of the common symptoms that are exhibited by patients who do have experienced ICANS, assessments that can be used to categorize and grade ICANS, and then some of the nursing interventions for patients who do experience ICANS, and then how those are treated. I wish I had an answer from many previous presentations on ICANS of why does it occur, but the etiology is still unknown. There is some science behind the permeability of the blood-brain barrier, knowing that the CAR T cells do cross the blood-brain barrier. And again, just like cytokine release syndrome, this is most likely mediated by the inflammatory process and the release of multiple cytokines that occur when these CARs go to work on their targets. Many time points in which ICANS can occur. So like Chelsea mentioned, there's a variety of onset for CRS, and ICANS can occur in combination with CRS at the same time, or it can happen after CRS or prior to in the absence of CRS. And because of the onset of CRS being variable among the products, there's actually even one of the BCMA-directed products who the median time to onset is not until 7 days post-infusion. So the patient has the potential to experience ICANS prior to experiencing CRS. Usually the onset varies from about 4 days post-infusion up to 3 to 4 weeks post-infusion. This is why patients have to be monitored very closely for 4 weeks after infusion, because there is this potential of late onset ICANS that occur. There's a lot of ongoing research to understand the etiology of ICANS and how to mitigate this side effect. Early steroid administration may be available and may be approved in some of the products to decrease the severity of ICANS without impacting the efficacy of the CAR T cells. So in early studies, I remember at City of Hope, we had bright pink paper signs that were outside all of the CAR T infusion patients that said no steroids. There was a lot of trepidation in using steroids when patients were infused with CARs because they're lympholytic. We didn't want to kill off the CARs by treating patients with steroids. So there was always this fine balance of how to treat patients who had an extreme inflammatory response, but with ICANS, that is the recommended treatment is steroids. Due to the varied onset, patients are prohibited who have been treated with CAR T cell therapy from driving or operating machinery for 8 weeks post-infusion. This does require them to have a caregiver who can transport them to and from appointments, as they are frequently reevaluated for their response to CAR T cell therapy and possible side effects post-infusion. The incidence of ICANS is very wide. It ranges from patients who are treated with CAR T cells that experience this side effect. So some of the risk factors that increase the potential of a patient developing ICANS if they do have CRS. So they already have an inflammatory process, and knowing that these cytokines are circulating in high numbers and crossing the blood-brain barrier, that does increase the patient's risk for ICANS. Others include pre-existing neurological conditions if they have a high disease burden when they're treated with CAR T cells. So if the CARs have a lot of disease to work on, this does increase the patient's risk of experiencing ICANS. Patients who are treated with CAR T cell therapy with a diagnosis of acute lymphoblastic leukemia are at higher risk for developing ICANS. The number of CAR Ts that they're treated with, what peak expansion the CAR T has, if the patient has an elevated ferritin level less than 72 hours post-infusion, and if they have an elevated LDH and thrombocytopenia prior to CAR T cell infusion, this does increase the risk of experiencing ICANS post-infusion. So ICANS can present with a variety of symptoms. It can be very mild. The patient can experience headache, and like Chelsea explained with CRS, patients may feel like they have flu-like symptoms, which can include headache. They may have impaired speech or can be completely aphasic. They're unable to speak. They may experience tremor, confusion, delirium, lethargy, obtundation, and changes in handwriting. So one of the pieces of the ICE assessment is a handwriting assessment, because some of the early studies found that subtle changes to handwriting were early indications that the patient was starting to experience ICANS. Cerebral edema is grade 4 ICANS and is rare, but is possible and is often fatal. These symptoms are transient and resolve generally, and symptoms usually take longer to resolve when patients experience ICANS than if they have just CRS symptoms. So it's nice to see when patients have symptoms of CRS, generally the treatments help to resolve the symptoms very quickly. With ICANS, sometimes the dexamethasone treatment can take a while for the symptoms to resolve, which generally is not a problem for the patient. They generally don't remember their experience with ICANS. The caregiver or the loved ones, the family members, are the ones who have a hard time, particularly dependent on the symptoms that the patient exhibits when they are experiencing ICANS. So Sarah mentioned the ICE assessment, or the immune effector cell-associated encephalopathy score. This is part of a bigger assessment, and I will show you in the next slide the ASTCT consensus criteria for grading ICANS. But the nursing portion is the ICE assessment. So this is utilized in adult patients. For pediatric patients, this is replaced with the Cornell assessment of pediatric delirium scale. And again, the ICE assessment is scored based on the patient's ability to do the following activities. So are they able to answer their orientation questions, name 3 common objects, follow simple commands, write a standard sentence, and has the writing changed any from baseline, and then their ability to concentrate and count backwards from 10. An interesting experience yesterday with a patient who was infused. The patient couldn't do the math, so he couldn't subtract by tens to do the counting backwards. So because that was his baseline assessment, I worked with the nurse to say, let's leave that as the baseline, because if he can't count back from 10 starting, it won't be an indicator of neurotoxicity. We'll have to use the other pieces of the ICANS score in order to assess that patient. So Chelsea spoke about the ASTCT consensus grading criteria for CRS. They also have one for ICANS for adults. So the ICE score is the top line. So anything less than 10 is considered abnormal in an adult patient population. And then the provider assesses the remainder of the components, which include the level of consciousness, if the patient experiences seizures, motor findings, and then hopefully not, but increased intracranial pressure and cerebral edema. So nursing interventions for ICANS include completing the ICE score. And for someone who asked online, how often is the ICE score completed? I apologize to put off your question, but I knew I was going to answer it in my presentation. So generally, ICE scores are completed at baseline, so prior to the infusion of the CAR T cells, and then post-infusion at intervals per the institution preference or policy. At City of Hope, we complete an ICE score every shift for the patient, but those intervals may vary and may need to be reassessed if the patient does have noted changes. So if the patient starts to exhibit behavior, it may be important to increase the frequency of the ICE score in order to identify changes and be able to notify providers so they can intervene appropriately and in a timely fashion to decrease the risk of the patient having a higher level of ICANS. Handwriting assessment is part of the ICE score. So we use a standard sentence so that it can be compared. I know other institutions just ask the patient to write their name. They may ask them to choose any sentence they would like. Seizure precautions. So this is a little bit variable by institution. At City of Hope, the providers choose to prophylax patients starting on day of infusion with seizure prophylaxis. But I'm also speaking about medication intervention. So I'll talk a little bit about the most commonly used medication that's used for seizure prophylaxis. Other institutions choose not to implement seizure prophylaxis until the patient exhibits signs and symptoms of ICANS. So there's some variability there. Very important to notify a provider with any subtle changes. Early recognition and intervention does reduce morbidity or mortality in this patient population when it comes to the exhibiting ICANS symptoms. And then educating families and caregivers. I think they struggle the most seeing the behavior and the change in their loved ones' mentation or potentially their behavior based on their experience with ICANS. So helping them to understand this is transient. It may take the treatment some time to be effective, but this is a portion, and this is kind of the rocky road post-infusion that the patient can come out the other side and maintain and return to their baseline neuro status. I also think caregivers are a very good source of noticing subtle changes. They know these individuals, if they're family members, loved ones, they know them better. They know their habits and their personality traits. So something, if a healthcare provider has never interacted with this patient and isn't familiar with them, someone may think this is just a quirky behavior they have, whereas a caregiver or a family member may say, this is very off. This is not how their normal behavior. So really paying attention to caregivers and family members, noticing subtle changes can help with early intervention as well. So treating ICANS, neurology colleagues are very good people to have on board. They help with consulting and trying to rule out other causes. Imaging is very important, so either MRI or CT of the head to rule out any other causes of the symptoms, make sure the patient doesn't have some type of hemorrhagic event. Higher grades of ICANS may warrant a lumbar puncture to rule out infection if it's appropriate for the patient. Corticosteroids are the gold standard treatment for ICANS. So again, the corticosteroid administration can impact CAR T cell proliferation and function. So there have been a lot of studies that show that the CAR T cells can persist through short courses of steroids, which is what we want for disease control. So this is the gold standard treatment for ICANS. It does help with the inflammatory process and helps to resolve the symptoms, but again, varies by patient in the timing that the symptoms do resolve. Corticosteroids in combination with anti-cytokine therapy if the patient is experiencing ICANS concurrently with CRS. So tocilizumab is the mainstay for CRS treatment, and it does not cross the blood-brain barrier. So this is not used if patient is experiencing ICANS alone. It's used in combination with corticosteroids if the patient is experiencing concurrent cytokine release syndrome and ICANS. And like I said, there isn't a standard for anti-seizure therapy. There are different approaches. Some institutions choose to prophylax all patients prior to infusion. Prophylaxis can be initiated if the patient experiences CRS or ICANS, or the patient can not be prophylaxed or treated for seizures unless they start to experience neurological symptoms. Levetiracetam is the drug of choice for seizure prophylaxis due to the fewer side effects that it has and lower drug-drug interactions, particularly if patients who are older and have comorbidities are being treated with CAR T cell therapy. That wraps up the other big side effect of CAR T cells, ICANS. And I think we will move on to early side effects.